Okay, great. Thank you for joining. This is the February 23rd webinar of Connecticut Sustanet Patient-Centered Medical Home and Healthcare Quality and Provider Advisory Committees. I'm Ellen Andrews. I co-chair the Medical Home Committee with Dr. Tori Westbrook. The Quality Committee is co-chaired by Margaret Flinter and Todd Staub. Today we're hearing about patient-centered medical homes and payment reform in two states that are leading in both areas, Vermont and Pennsylvania. First, we're going to hear from Jim Hester. Jim is the director of the Healthcare Reform Commission for the Vermont State Legislature. The commission is charged with overseeing the implementation of the comprehensive package of health reform legislation passed in 2006 and recommending a long-term strategy to ensure that all Vermonters have access to affordable quality health care. Jim has 35 years of experience in the healthcare field and has held senior management positions in at least a dozen healthcare places that it would take me forever to read. The really cool thing is he earned his doctorate in urban studies and his master's and bachelor's degrees in aeronautics and astronautics from MIT, and he also holds a master's of education from St. Michael's College. And every time I talk to Jim, I learn three new things. I learned three new things just this morning in our conversation, so I'm very excited to hear what Jim has to say. We can get started, Jim. Oh, some housekeeping. I'm sorry, I will do that. If you're listening on the phone, remember to input the audio pin that should be visible on your screen if you want to be able to talk and ask questions. If you're listening on a headset directly through your computer, you don't need the audio pin. And we'll be keeping everyone on mute until all the speakers are finished with their presentations, and then we'll have some time for questions. To ask a question, you can raise your hand by pressing that button. But to save time and be sure you don't forget them, you can also type them into the question pane at the bottom of the screen at any point in the webinar, and the slides and a video of this webinar will be posted online soon. Great, Jim.
Okay, why don't you go and go to the next slide.
Okay.
It's a pleasure to talk to you this afternoon. This is an outline of what we're going to be going through in my presentation. I want to start off by giving you a little bit of context about Vermont healthcare reform. Our work in payment reform and medical homes not being done in a vacuum is part of a larger healthcare reform strategy, as you'll see. But then we're going to focus on building what we're calling a community health system. We'll talk a little bit about the conceptual framework of that. And then the enhanced medical home pilots we have underway are phase one of that work. And development of an accountable care organization pilot is phase two, and we're just getting started. I'll give you a little bit of introduction what's happening on that. Then we'll talk a little bit about the sort of key findings and conclusions and current status and next steps. The next slide. So the Vermont healthcare reform, this is Vermont. Each one of those areas on the map is a separate hospital service area. And we're using these hospital service areas for defining our community health systems. We're fortunate in that we have no communities with competing hospitals. All of our hospitals have essentially a franchise for the service area that they are responsible for. And that has actually helped quite a bit in terms of establishing a collaborative environment for our work. We have three major commercial payers, and then Medicaid and Medicare. And again, one of the features of the state is a history of collaboration, both bipartisan. We have a Republican administration and a democratically controlled legislature that have been collaborating on this for the last 8 years, and also in collaboration across multi-stakeholders has been essential for putting this work together. Next slide. So the reform strategy that Vermont developed was really embodied in Act 191, which was passed almost 4 years ago now, in 2006, which created a three-legged stool which balanced, first of all, a focus on trying to have a sustainable reduction in on a number of uninsured in the state. We were running about 10% at the time, and we established the goal in the legislation of reducing that to 4% by 2010. We had considered trying to do a universal mandate the way Massachusetts did, but frankly, we didn't have the money to afford the subsidies that were required to do that. And so we went to a little bit more modest goal of a substantial reduction rather than trying to get absolutely universal. The second leg of the stool was health information technology as a catalyst for improved performance. And as we'll see, as we get into the delivery system reform work, this has been an absolutely essential part of the work that we've been doing. And then finally, in order to have the reductions in the number of uninsured be sustainable over time, we had to do something about that fundamental issue of bending the medical cost curve. And our focus on that was using delivery system reform through a program that we call the Blueprint for Health, that was initially focused on chronic illness prevention and care and has expanded, as we'll describe, from that. So reducing the uninsured, health information technology, and bending the medical cost curve were the elements, the main themes of the reform strategy. There are a variety of other supporting projects, about 6 of them in all, but this captures the main substance. This work had 5 years in preparation before the legislation was passed in 2006. The focus on chronic illness care actually started with a study group led by the Secretary of the Agency for Human Services and the President of the Vermont Hospital Association, which looked at the sickest 10% of the population and sort of how we can improve care for that group. That led to some statewide learning collaboratives that were sponsored by our statewide Quality Improvement Organization, Vermont Program for Quality Healthcare, VPQHC. So, those collaboratives, we had 3 different waves of them between 2001 and 2005. And we developed this public-private partnership in the Blueprint for Health between the commercial payers and the public payers, with everyone recognizing we were not going to get the changes they were looking for with payers working individually. So this all-payer element of our reform started early and has continued as one of our major characteristics. On the health information technology side, there was a study group led by the Hospital Association, which led to the creation of the statewide Regional Health Information Exchange the year before the reform legislation was passed. Next slide.
Oops.
So I'll do a quick recap. I'll skip 2.
I skipped too far, didn't I?
Yeah. So just a quick, back 1, forward 1, there we go.
There we go.
Status on reducing the uninsured. We offered some new commercial products just for the uninsured, starting a little over 2 years ago. Major outreach to the uninsured by a wide range of organizations. And as of last December, we had about 12,000 new people enrolled in Catamount, 17,000 enrollees in state programs, and we had reduced the number of uninsured from 10% to 7% in a declining economy. So we had not achieved that goal of 4%, but we felt we'd made pretty significant progress. Next one. On the health information technology, the statewide health information exchange network has been funded and is being built out. The statewide health IT plan was developed and approved, and we had pilot programs going in both medication histories in ERs and for primary electronic medical records for primary care physicians. One of the things that was unique to the state is that we came up with a health information technology fund for the state that was funded by a fee on paid claims, which was designed to provide funding for electronic medical records for all independent primary care physicians in the state and to fund the health information exchange. This turned out to be very fortuitous as the Federal Stimulus Act passed the high-tech component of which provided the federal funding, which we are matching and moving forward. So the program was extremely well timed. Again, the goal here was not information technology for itself, but as a driver for transformation of the system, which leads into the status of that third piece, which is building the community health system and controlling the rate of expansion of medical costs. It's one of the truisms of our world that every system is perfectly designed to obtain the results that it achieves, and if you want to change the results, you've got to change the system. And so our approach is to take a look at system redesign at four complementary and reinforcing levels. The first one is the primary care practice level, and this is our work with the enhanced medical homes, which we'll get into more detail in a moment. The second level, moving up from the primary care practice, is the community healthcare system, which is really what Fisher's called the neighborhood for the medical home. It's the community hospital where they practice, the specialists they work with, and other providers in that local community health system, which support a given population. The third level, and one that we've put a lot of time and energy into, is developing the state and regional infrastructure which support what's going on at the medical home level and at the community health system level. For example, our health information technology work and some of the payment reform work, as we'll describe in more detail. And finally, there is essential to have a national component of the system design, particularly in order to get Medicare participation, because Medicare is critical for driving some of the changes we're looking for at the primary care practice and the community health system level. The other feature of our approach is that given the scope of what we were trying to do, we could not do it statewide at the outset. And we made the deliberate decision to start in pilot communities, both for the medical home work initiative and for the community health system, ACO type of work. That strategy has really worked quite well for us. We essentially had an active competition between our different communities to qualify for the pilot. It helped energize the work, get it started, and we feel it was essential to being able to make the progress we have. Next slide. So the building blocks for our community health system were really four. The first one was the chronic care model that was developed by Wagner. This was the starting point for our Blueprint for Health. We're focused on chronic illness care in our pilot communities when we first got started. One of the refinements that we made was to add the prevention component to Wagner's model, and as you'll see, that's carried through in our work today. In 2007, we expanded the chronic care model to the enhanced medical home to move beyond chronic illness to be able to cover all primary care and begin building a more community-based population health focus. The third element of our building blocks was the IHI Triple Aims program. The Triple Aims are essentially trying to improve system performance by optimizing the combination of total per capita medical costs, second, the patient experience of care when they need care, and third, the outcomes or health status of the population that you're caring for. We were one of the initial participants in the Triple Aim work and have carried that on for the last 3 years. And then the final building block, as we started getting some success on the medical home side and the primary care side, was the work in introducing the Accountable Care Organization pilot. We did a feasibility study in 2008 that was commissioned by the legislature, and then working on to get our first pilot going, as we'll describe in more detail. So those four building blocks, the chronic care model, the enhanced medical homes, the Triple Aims, and our ACO work are sort of how we've approached that community health system. Next slide. This work is designed at building systemness in a very fragmented system, and the key generic functions that we're looking to create, to build or to strengthen where they may exist partially at the current time, are first of all the service integration across the levels in the setting of care. Second, financial integration, particularly having a consistent set of financial models across multiple payers and local management of integrated budgets. the governance of the local organization, the information that's required to support not only care management on a day-to-day basis, but also process improvement and evaluation over time. And finally, the process improvement skills to design. We use this information to improve performance both in our care processes and the and administrative processes. So those are sort of the 5 generic functions that we're trying to put in place. Payment reform is recognized as an essential but not sufficient component of this reform. It's remarkably difficult, as I'm sure most of you appreciate, particularly in integrating the payment reform across payers. Phase 1 of our payment reform has been this medical home pilot and changing the reimbursement for the primary care practices. Phase 2, as we'll see, broadens the incentives to the other community providers beyond primary care. Next slide. So, community-based, medical home pilots. What have we been doing? This is a recap of the components of the enhanced medical home pilots we've implemented. It incorporates payment reform for the primary care using the NCQA patient-centered medical home model. There is a sliding scale care management fee, which I'll describe in more detail in a minute, which is linked to the NCQA patient-centered medical home criteria. The second element is we found that our primary care practices could not functionally do the work of the medical home using the existing staffing resources that were available in primary care practices, both smaller practices and actually some of the larger practices in our academic medical center. So to deal with, again, the need to have new functional capability, one of the things that we've done that's fairly unique is introduced a community health team into each one of our pilot communities, which is funded by payers. As you'll see, it's about 5 new FTEs, full-time equivalent staff, for supporting a population of about 20,000 people to let the medical home function the way that it needs to. One of the cornerstones of our work is all payer participation. The legislature ended up mandating participation by the 3 commercial payers. Medicaid was on board from the outset. And we did not go for a Medicare waiver because of the time involved, but the state is actually making the payments for the Medicare patients so that any given provider has all the patients in their panel covered by the payment reform. The fourth element was a community-based prevention plan, using evidence-based interventions. The fifth element was very strong IT support to support the work of the medical home. We'll go into this again in a little bit more detail, but we have a web-based clinical tracking tool called DocSite, which is being used by all of the practices. If the practices do have EMRs, and a number of them do, we've built the interfaces into the clinical tracking tool and exchanging the information across sites through our health information exchange. Our timeline, we introduced this medical home pilots into 3 communities by the end of last year. Roughly 20,000 active patients in each one of those pilots, a total of 60,000 residents, which is about 10% of the Vermont population, which is currently engaged. Next slide. So the objective of this pilot was, as laid out on this slide, we wanted to see if it was possible to, first of all, have the practices meet the nationally recognized standards for a patient-centered medical home. Then if they did that, we want to see whether there was an increase in the patients who received guideline-based care for the various conditions. The next step was to see if we got an increase in the proportion of patients that had actual improved outcomes, the control of their conditions. And then in general, a shift from episodic to preventive patterns of care. We're trying to document whether we're achieving these objectives in a structured evaluation, which we're describing as we get into this next slide. So this slide lays out the elements of the integrated pilot in a little bit more detail. So the financial reform, the payment based on the NCQA standards. Why don't you advance it to the next slide, Ellen? This shows that sliding scale fee that I mentioned. Essentially, every 6 months, we have an outside team of assessors come into each one of the pilot practices and do an assessment using the NCQA algorithm. The scoring is reviewed by NCQA and validated by them. And so the higher that the practice scores, so you see the bottom scale, ranging from 0 to 100, the more they get paid. They have to meet a threshold of at least half of the mandatory program elements in order to qualify for anything. That jumps them up to about $1.25 PMPM. And then as they get more mature and have more functionality, they move up that curve, or the upper end is just about a little under $2.50 per member per month. To give you an idea of what this means, for a practice with 2,000 active patients, that $2.50 per member per month is $5,000 per month, or $60,000 per year per physician. That's serious money, and has had been a major motivator for our practices to meet those NCQA requirements. Why don't you go back to the previous slide? So what happens is in addition to the payment directly to the practice based on that sliding fee, the other piece of the financial reform is that the cost of the community care teams that I described are also shared by all of the providers, the payers. That is paid for by the payers for care, not by the practice. Again, Medicaid and the commercial payers are paying a proportional share of the community care teams. For the payment to the practices, each payer takes the score that's verified every 6 months and then makes a payment to the practice based on the panel size that each payer has. So each, Blue Cross, say I have 1,000 patients with this practice, they do $2 per member per month, so send them a check for $2,000 each month. Okay, the second element of the care support teams, why don't we go forward a couple of slides, that one. This is an example of a community care team. This is the one that's in St. Johnsbury. The circle to the left is the primary care office with their staff of physicians, etc. And some elements of the community care team are actually embedded in the practices or rotate through them. So in this case, it's a behavioral health specialist and a chronic care coordinator that actually spends some time in the practice office. There are other resources of the care team which are based in the community at large, typically, usually at the hospital. This includes some community connectors, community social workers, and community health worker types who are very knowledgeable about resources in the community, can work with the physicians and their offices in terms of following up with the patients on tasks such as linking them in for nutrition programs, walking programs, behavior and supporting behavior change for people with chronic illnesses, etc. The Vermont Department of Health has a member of the community health team who is their prevention specialist, and we'll talk more about that work in a minute. So this is, again, 5 new FTE staff that were not there before, who are a resource for the primary care practices that enable them to function as a medical home more effectively. Why don't you back up 2 slides? The third element of the health information technology, again, there's a doc site program which is a web-based clinical tracking system. This program provides visit planners and population-based reports. We also have support for electronic prescribing. One of the things I want to emphasize is that even for practices that have electronic medical records in place and have been using them on an ongoing basis, they have found that it's essential to have, to feed their information into the dockside clinical lab tracking system in order to do the population-based report and assessments that are required to manage a population on an ongoing basis. So the dockside system is not viewed as duplicative. It is a complementary piece of technology, for the practices. For the community activation and prevention program, each one of the pilot programs is developing a community profile and risk assessment to assess what are the specific needs in their community, and then prioritizing the evidence-based interventions that they're recommending based on the local needs of the community. So this prevention side has been an active and integrated piece of the work, from the outset. The evaluation of the program is really structured to be used input from a number of data sources that are already in place and being used on an operational basis. There's no extra or additional data collection work that's required by the practice to produce the information for the evaluation. So when, for example, the NCQA assessment of the patient-centered medical home is done, that is part of the input for the evaluation. It gives us some indication of the process measures in the practice, where they are in terms of process they're using. We have clinical process and health status measures that are being supplied out of the dockside clinical tracking system. So the information that's being used for the care and tracking the care is available for the evaluation. Finally, we have an all-payer, multi-payer claims database that has been implemented statewide that provides us information on the patients in the practice, in the pilot, so that we can track utilization and cost and compare those to a matched sample outside. Next slide. Next slide. So this is just putting what was previous.
Oh, sorry.
Oh, you can leave it here. It's okay. This puts into a bubble chart format the things that was in the bullet points before. So what you have is in the local community, the hospital, the various patient-centered medical home practices, mental health providers, and public health, all being held together by that community care team of a nurse coordinator and the other folks that are participating in that. The little diagrams on the side break out some of the specific elements of the healthcare information framework and the evaluation framework and the uses of that information. I'm not going to repeat that once again, but it's just a visual way of representing the structure of the program and where the information, how the information flows. Next slide. So this is the plan for the expansion of the medical homes. Each line going across represents a hospital service area. So the top 3 lines are the 3 existing pilots, 1, 2, and 3 in our 3 communities. Below that, you can see we're doing the readiness work in 2 additional communities and expect to have them turned on July of this year. And then we're planning for the rollout of the rest of the communities in the state over the next year. At the present time, look at the bottom of the chart. With the present time, we actually have 60,000 people, 10% of the population, in 3 of these community health teams. You see that that's supposed to expand over time until at the end of this period, July 2013, we expect to have all of the Vermont population supported. It'll take about 30 of our community health teams in order to do that. And we're just right in the process of developing the plans to make this possible and to support it. A key element to being able to do this is obviously the Medicare participation, and we'll talk about how we're approaching that in a second. Next slide. This is what's involved in building the capacity for that kind of expansion. We have a central blueprint team that's housed in the Department of Health with their staff centrally. We have blueprint facilitators, 8 of them divided among the communities that do the project management work and some technical facilitation. And then there's local leadership and the other folks you expect to see supporting this process at the local level. Next slide. So the status is, again, we've got the 3 going. These have been extremely well received by the patients, by the physicians, by the staff. The evaluation data is still in process. We're new enough. We don't have solid statistical data, but the early results we're getting in terms of the impact on emergency room use, the impact on readmissions, we're seeing that things moving in the direction that we anticipated from the results in other medical home work. The Department of Health and Human Services has announced a set of state-based multi-payer pilots, to support advanced primary care models, which is based on the Vermont program design. They announced that late last fall, towards the end of last year. We're expecting the program design specifications to be coming out in the next month, and we'll be applying for that. And that is an essential prerequisite, obtaining CMS support so that CMS will start paying for the Medicare share of our enhanced medical home pilots is essential to the expansion. The state can no longer afford to pay Medicare's share to grow beyond where we are today. So we're looking forward to that. I just want to mention that one of the things, in addition to the statewide pilots, there was also conversations about a multi-state evaluation collaborative for a shared evaluation in which there may be some pooling of data, some coordination of the evaluation design. And it's a very interesting development from the multi-state collaborative that has been working under the sponsorship of Milbank Foundation for about the last 9 months or so. Next slide. So what's this all supposed to do? And we've done some modeling of if we get the kinds of results in terms of improvements in chronic illness care that Geisinger, that North Carolina, other medical homes have experienced. If we cut those in half, and only have half the results, we see the results shown on this slide, where on the axis, the left-hand axis, is the incremental cost in total medical costs in the state of Vermont for each year. So you see the growth, the increase in cost in the $300 million per year range. The top line is what happens without the blue medical homes. The bottom line is what happens with a rollout, which had 40% of the state covered in 2013. It was more modest than we were planning at the current time. We actually see a bending of that total incremental cost curve if we get those results. Next slide. Now, in order to actually achieve those savings, you need to move to the next level of payment reform, and that's where we get to our phase 2 work. The savings from reduced hospitalization, reduced ER visits, etc., are only potential savings unless you actually pull costs out of the system. Utilization changes don't do it by themselves. If you're reducing the ER use, you have to see reduction in total costs there, which means the hospital changing the way that they do business. So in order to realize that potential, we're focusing on, again, the ACO type of model and extending the payment reform beyond the primary care physician to include the specialist and the community hospital. Part of the intent here is to capture a piece of the savings through a shared saving model to reinvest back into the local community health system. If we don't do anything, and we see a reduction in the use and reduction in cost, those savings simply flow downstream to the payers. Nothing happens in terms of, there's no incentive to the community, which results from those changes. So we wanted to have a savings sharing model which would keep some of those savings locally that could be used in some cases for transition funding as the parts of the system need to adjust to the new use patterns, but also to use for investments in population health, primary care, etc. Next slide. The goals of our pilot were to improve the performance in those IHI triple aims that I mentioned before. Bending the medical cost curve to significant savings over projected trend line of cost. We think if we can get a 2 to 3% bending per year, that is significant. But also to improve the health of the population and the patient experience. We wanted to test this concept of ACO in a small number of early adapter community provider networks that are starting off with some of the capabilities that are needed to make this work. And the short-term goal was to have at least one Vermont site in the National ACO Learning Collaborative and Learning Network that had been organized by the Dartmouth Institute and Brookings and is currently operational. Next slide. So the way that we approach this is the Commission took on this task. Again, we were charged by some of the legislation that passed in 2008 and 2009. We wanted to do a feasibility study which created a working design for the ACO and assess some of the critical issues and tasks such as the scale and scope of the pilot, what are the responsibilities of an ACO, what are some criteria for being an effective ACO, what's the financial model look like, including the incentive structure, and how do you fund this thing? We educated a broad-based work group of stakeholders throughout the state over the last 2 years. And we wanted to provide support to several of our provider communities for development of the pilot application for that collaborative. In this case, we could not fund our own ACO program. We just, for a whole host of reasons, we ran out of money. So we needed to piggyback on the work that was being done nationally, and that's how we approached it. Next slide. So in terms of what we found in our feasibility study, we have these functional capabilities I talked about at the beginning of the presentation of service integration, financial integration, governance, IT tools, process improvement. And we have, whoops. Hello? Ella?
Sorry.
All right. Yeah. And what happens is those functional capabilities have to exist at multiple levels in the system. Some of them exist at the primary care practice level, at the community health system level, at the regional level, national level. And I'm not going to take you through all of the next 3 slides in detail, but just suffice it to say that in order to build this system, you have to work at all 4 of those levels, and it's a set of interlocking capabilities so that the primary care practice gets supported by what's happening in the local community health system. It also gets supported by the state resources and ultimately supported by the federal resources. So if folks want to take a look at the presentation at another time, the next 3 slides will just give, I'll show them to you briefly. Next slide. This is looking at service integration and financial integration, and then the last one was the information tools by level and sort of laying out what happens at each level and how do they support each other. Next slide. So our conclusions, we find that working at the community health system is the focal point of delivery system reform. People talk about delivery system reform happening at the federal level, at the state level, but where the rubber really meets the road, where the capabilities have to be built, is at this community health system of the primary care physician, the specialists they work with, and the hospital, integrating their care across sites of care, supporting a defined population, and developing the local resources to support healthy behaviors. Next slide. We find that the ACO is a promising financial reform which should be tested. It's got to have Medicare. That a successful ACO pilot is really enhanced and dependent upon some key prerequisites. And in particular, we do not think that you should start trying to do an ACO until you have a strong medical home model, including the primary care payment reform, in place in the community. It also requires strong IT support, and this thing will not fly using just paper medical records and traditional paper processes. Those prerequisites required a lot of work, and even with work that we've been doing, we feel that we're still 6 to 12 months away from completing the foundation work for an ACO. We're not targeting our first ACO until the early part of 2011. Next slide. Just to skip over that. Next slide. So in terms of status on the ACO, we got not one, but three qualified pilot sites participating in that national learning network. We are creating an all-payer model for this. So the three major commercial payers are participating and willing to have a consolidated shared savings pool. The Medicaid plan for Medicaid participation is under development and due this summer. And we're looking for Medicare participation. All of our national reform bills have Medicare participation as one of their elements. That's obviously stalled, but there's active conversation about a Medicare pilot to support this. Again, we cannot start our work without a clear pathway for Medicare participating. We've developed a financial impact model with the support of the Commonwealth Fund for the ACO, which shows exactly how the ACO would work in a specific community, the impact on the hospital cost structure and the physician structure, and it's providing a very useful planning tool. There's draft legislation in place to accelerate the expansion to half of the state by the end of 2012, sort of paralleling the development of the medical home. And this is obviously, we'll be coordinating and integrating development with the Blueprint Medical Home. Next slide. And this is my favorite quote from Churchill: "You can count on Americans to do the right thing after they've tried everything else." We've tried a lot of stuff, but I think we feel like we're on the right track with this combination of the medical homes and the pilot. And the last two slides are just resources, both on Vermont healthcare reform, and the last one is the key players in the administration, particularly on the Blueprint for Health work, in case you wanted to have contact with them. So that's the presentation. That's our story. I've got some time for questions.
Great. Well, nobody's raised their hand or typed in one, so I am going to take the prerogative of asking mine. How did you decide where to pilot this? Which communities to start with?
As I said, we actually ran a competition where we laid out criteria saying this is what we're looking for, this is what the local community needs to provide, and we had applications developed by 2 to 3 times the number of communities that we had available. So there was a competition, and then we did an assessment in terms of the degree of support of the primary care physicians in the area, the leadership, the willingness to provide some in-kind staffing and contributions, etc. So there was a structured evaluation to try and improve the likelihood for success.
And who keeps the database, the data for the evaluation and the coordination? Where is that housed?
The key data is housed in that DocSite web-based clinical tracking tool, and that's actually housed in the statewide health information exchange.
And who owns that? Is that the state? Is it a state agency or?
The state agency.
Okay.
And in addition, again, the all-payer claims database is created in a parallel effort and is administered and owned by the state agency that administers the health insurance plans.
Okay. And just to be sure, the teams, the community care teams, those are in addition to what the practice gets in terms of like $250 or whatever per member per month?
That is in addition. There's two different sources of payment from the providers. The providers, excuse me, each payer pays the practice its PMPM care management fee, and then in addition, each payer is assessed an allocation of the community health team costs. Those are two separate payments. Between the two of them, the maximum, the care management fee has a maximum of $2.50 PMPM. The community health teams, the total cost is about $1.50 per member per month. So so the maximum obligation is about $4 PMPM between the two.
And how much is it costing the state? I know it's probably a touchy area, but to cover the Medicare patients?
About $1 million.
Oh, for a year?
For a year.
That's not so bad.
Not too bad. We could handle that. We'd like to have it back.
Sure. And that's only for 10%. If it grew, that would be more.
Yeah.
And how do you keep, this is something we talked about last night in our meeting around patient-centered medical homes. How do you keep everybody on the same page and communicate across? Every time I hear from Vermont, I think about all these balls you have in the air. And whenever I talk to anybody there, they always know what everybody else is doing. Everybody's on the same page, and that's just so hard to do in Connecticut and probably in other states. How do you keep the communication flowing?
Oh, you work real hard at it. So the blueprint, for example, has an executive committee which has all the major stakeholders on it. We meet monthly and work with the executive director. The Health Information Exchange, vital. Its board also has most of the major stakeholders on it. There's a lot of crossover between those two, and then the we just spend a lot of time in meetings with each other and communicating results. So I don't know any way to describe it. So there's some structural work that's done in the way that we set up our steering committees and executive committees, but there's also just a pretty steady stream of information flow between the major players.
I was just hoping there was some easy answer, but no, it's just
There's not an easy answer. Part of it is, it's sort of in the genes up here. We have a variety of multi-stakeholder institutions like the statewide Quality Improvement Organization, Vermont Program for Quality Healthcare, where that is traditionally provided informal forums for people to stay in touch as well. Mm-hmm. So it's one of the things it's just health across the board. It's people are used to doing.
Tori has a question. Do you get any resistance on the 0.2% surcharge to fund the vital system?
We did not. It was a small enough, 0.2%. Was like $6, per person, on a typical premium, and it was small enough that even though a Democratic legislature passed it, a Republican governor signed it. All right, so and it happened just before the current financial crisis. I don't know what would happen if it came up today, but it was a small enough assessment and yet over a 7-year period, it developed a fund of about $20 million to support it, and it's actually now being imitated in a number of other states that are looking at it. But particularly as a source for matching funds for the federal stimulus,
interesting.
health information exchange funds, it's a great. We're now getting 5-to-1, in some cases 10-to-1 matches for those state funds through the national initiatives, which is everyone loves that.
Yeah. Ken Leem wanted to know who paid for the DocSite product and interfaces for multiple systems, and how was the $1.25 to $2.50 per member per month incentive determined?
The incentive was something that was a series of negotiations between the Blueprint leadership and the payers in terms of coming up with something that was appropriate and provided a meaningful incentive but didn't break the bank. And what was the first question?
Who paid for a DocSite?
The DocSite was funded by the Blueprint. It was part of their initial budget. The connections to DocSite are being built out as part of the exchange. So the prep work as we go into an area, that's one of the things we do, is build those interfaces between the hospital and between the practices. One of the things that Vital has done, which was sort of, you can see how these lock together, interlock together. In Vital, it's providing support to primary care practices in installing electronic medical records. They have a program of preferred vendors, and in order to be a preferred vendor, you have to develop the interface, to DocSite and to the health information. Actually, it's an interface to the health information exchange, because once you're linked to the exchange, you're linked to DocSite. So, one of the benefits of this is the practices are getting linked into the statewide health information exchange as part of this readiness work.
Great. We have one more question from Judith Myers. Could you describe a little more about the ACO National Learning Collaborative Network?
Yeah. Brookings and Dartmouth have been sponsoring this. They've been strongly supportive of the ACO concept for a while. So they have a learning collaborative, which is a small number. I think it's 3 or 4 sites that are actually implementing the ACO and sort of providing initial samples. And then they also have a learning network, which is a larger number of sites, I think it's 35 or 40, that are participating in monthly seminars and learning from each other and sort of learning what's involved in this and preparing to become an ACO. So it's a very interesting opportunity for provider organizations in particular to get more comfortable with the concept of the ACO and what might be involved, and to learn from some other organizations around the country.
Well, great. Well, thank you very, very much. And I think we have your email, and you'll be sorry you gave that to us.
Yeah.
Well,
good luck. I mean, you see, it's been a long road. We've been at it for a while, but I really believe that there's some important changes that are actually taking hold, as I said, at the community level, at the practice and the community system level, and this is, it's good stuff.
Great. Well, thank you very much.
My pleasure.
Next, we're going to hear from Ann Torregrossa. She is the Director of the Governor's Office of Healthcare Reform. She oversees and coordinates the administration's continued commitment to being a national leader in healthcare reform. She's developing the prescription for Pennsylvania, the administration's plan to provide affordable, accessible, quality healthcare coverage and long-term living services to all of Pennsylvania. She's an attorney with 38 years of experience in Medicaid law and health policy. Kindred spirit. She has taught at the University of Pennsylvania and Villanova University School of Law, where she was a graduate. Ann, are you still there?
I am.
Great.
It's so nice to be with you, and I really appreciate the opportunity to share what we're doing in Pennsylvania and hear what you're all thinking about and hear more about Vermont. So this has been great. Can we do the next slide, please?
Sure.
As Ellen has said, our work in the primary care transformation area really came out of our attempt to come up with an integrated healthcare reform proposal, which we called RX for PA. And as you can see from the logo, we think that these components are totally interrelated, and you can't really take on one without taking on all of them. Next slide, please. As you can see also from this chart, RX for PA was pretty comprehensive and had a lot of components. Happily for us all, I'm not going to go through all of these, but if you want to see the entire plan, you can go to the Governor's Office of Healthcare Reform, Pennsylvania, and find it online. Next slide, please. The first thing that we did to transfer how primary care is delivered was to address the scope of practice law changes that we need. Pennsylvania had absolutely the worst scope of practice laws in the country. Our medical society is very, very strong, and we were practicing, I think, in the 1800s as far as I was concerned. For instance, we were the only state where nurse midwives could not prescribe, even though we have the most rural population who often depend on nurse midwives. We knew that in order to ensure that we could have an interdisciplinary team working on primary care, that we needed to really change our scope of practice laws. We were able to get through the legislature, and it was not a pretty scene, changes in our CRNP, nurse midwife, dental hygienist, pharmacist, physical therapist, and physician assistants, so that they now are able to practice to the full extent of their training and education. Just to give you some idea of how this can affect access, and Pennsylvania had 14% higher ER visits than the national average. Since the CRNP change in law, 41 clinics have opened up, employing 200 nurses with about 300,000 visits a year. We estimate that about half of those would have gone to ERs. So the first thing, I think, lesson that comes out of this for us is that, particularly given the projected workforce shortages and the aging population that face us, that it's really critical to make sure that you are able to have all of your healthcare providers able to practice to the full extent of their training and education. Next slide, please. Primary care is not in a good place in Pennsylvania right now. In fact, some people say it's on life support. About 20% of our primary care physicians plan to leave practice in the next 5 years, and 43% within 10 years. And we have very, very few residents going into primary care. When surveyed about this, residents indicate that they don't like the chaos of primary care practice, feeling like they're on a hamster wheel, seeing patients every few minutes, unable to spend the time with people with multiple chronic conditions that they need to, and that the reimbursement really does not leave a very good lifestyle after they pay off their extensive student loans. Practices are also not practicing very efficiently. Most of the face time with the patient is with the doctor, and the net result in all of this is that it's not good for the practitioner, the patient, or our healthcare bottom line. Next slide, please. In developing the RX for PA, we started looking at the cost drivers for healthcare in our Commonwealth, and we found that about 80% of healthcare costs were for about 20% of patients with chronic conditions. And so this looked like a tremendous win-win of increasing quality for people while reducing cost. We have something called the Pennsylvania Healthcare Cost Containment Council that collects extensive data from hospitals. And we learned that in 2007, Pennsylvania hospitals charged over $4 billion, that's just for 1 year, for avoidable hospitalizations for those with chronic conditions. This did not include avoidable ER visits. So you can see that we're spending a lot of money for avoidable hospitalizations, which if people had gotten the care they needed in the community would not have been necessary. We also know that patients are only receiving about half of the evidence-based primary care that they need, and even less for those with chronic conditions. So it became really clear to us that we needed to both change how care was delivered at the primary care level and how it's paid for. And that kind of was the beginning of this whole primary care transformation effort that we started. Next slide, please. Whereas Vermont took 5 years from start to implementation, we took 1 year. And we were really learning by the seat of our pants, as you can see as we go along. Governor Rendell established the Chronic Care Management Reimbursement and Cost Reduction Commission by executive order in May 2007. He told them that he wanted a strategic plan on how to transform how care is delivered and paid for within 90 days of their first meeting. The commission was a little late on that, but they presented a strategic plan to the governor in February of 2008. And it really made the business case for combining both the chronic care model and the patient-centered medical home. I have the website for the strategic plan, and you might want to take a look at that. We felt that it was important to combine, as Vermont did, both of those models, because we didn't just want to focus on people with chronic conditions, but we wanted it to impact on all patients, and we wanted to also be involved with preventative care. So we started implementation in the Philadelphia area in May of 2008. We targeted diabetes because they have so many comorbidities, and pediatric asthma. The idea there was having patients focus on a target group so they could learn how to use a patient registry, they could change their workflow, and then have them branch out for all patients. We had strong partnerships with the Pennsylvania Academy of Family Practice, all of the insurance companies and payers except Medicare fee-for-service, and community stakeholders. Next slide, please. As I said, it was really critical to us to change not only how care was provided, but how it was paid for. We wanted to reward practices that transformed how they were providing care. And usually payers can't get together and discuss how they're going to pay physicians because that is an antitrust violation. But there is an exception to that, and if the state supervises the discussions and it's for purposes of improving public health, then these payers have antitrust safe harbor. So we were able to get all the payers except Medicare fee-for-service, including our Medicaid HMOs, to join in this effort. Happily, we didn't need legislation, as Vermont did, and we did not pay the Medicare fee-for-service portion. What we did was look at the tax filings of the practice and then do a pro rata assessment based on their revenue sources. We got all of the payers and primary care practices to commit to a 3-year initiative. We knew this was something that wasn't going to transform overnight. Next slide, please. So a critical thing on the payment that I wanted to mention is every physician had multiple arrangements with multiple payers and contracts, and we didn't want to mess with those. So the payments that we came up with were in addition to whatever per member per month or fee-for-service contract they had with the various providers, and in addition to any pay-for-performance that they had. And it would have been a contractual nightmare to do anything else. Basically, starting with Southeast, we had two payment components. One was an infrastructure component to help practices absorb the cost of getting involved with this. And so we asked the practices to select a team that would come to 7 days of training in the first year, and it had to be the physician or lead nurse, if it's a nurse-managed practice, so the CRMP, and it should be maybe an office manager and RN, And they would have to commit to coming to 7 days the first year and then 2 meetings for each of the second and third years thereafter. They have to agree to do pre-work before the Learning Collaborative. That is, take the patient registry that we provided to them. That was secure internet-based registry. Enter all their diabetics and pediatric asthmatics into it so that they then could see how they're doing on providing evidence-based care and the quality measures. They had to agree to provide monthly data using the patient registry and narrative reporting. They had to agree to work with practice coaches. They had to agree to participate in monthly conference calls. And they had to agree to apply for the patient-centered medical home recognition with NCQA within the first year. Next slide, please. You can see that there is a potential for some substantial reimbursement. And this was the second component of the payment. So in addition to the about $20,000 infrastructure payments they got to participate in this, depending on which level and the size of their practice, they could receive additional funding. So for instance, you can see from this chart that a sole practitioner who reached level 3 could receive an additional $95,000 a year, which is a lot of money for a primary care practitioner. Next slide, please. So in Southeast Pennsylvania, we had 32 practices. 9 were FQHCs, and we had a number of nurse-managed centers. They represented 236 PCPs, served about 209,000 patients, and were from a variety of primary care disciplines. We had all sizes of practices, from the big academic practices to the very small single PCP office. Some of the FQHCs who had been through HRSA collaboratives really were the mentors for some of these stuffy academic practices, and it was so much fun to see them really teaching these practices how to do patient self-management, how to accept that there's no such thing as a non-compliant patient, and always look behind why a patient is doing something, how to use a patient registry, etc. Next slide, please. So our first year outcomes were kind of exciting for us. We had all the practices achieve at least level 1 NCQA within the 12 months, so they all qualified for the enhanced payments. And you can see that we had some significant improvements in control over blood sugar, getting eye exams, foot exams, lowering cholesterol, and blood pressure. The things we did best on were the things that practices could control, such as foot exams or that kind of thing. Next slide, please. This gives you an idea of a preliminary result for one Medicaid HMO after 10 months. For the 1,452 diabetics that they were paying per member per month, there was an increase in prescription costs, which you would anticipate as people became more compliant on medication. But they had a 26% reduction in inpatient admissions, which is amazing, and a 18.4 reduction in ER visits. And so just in 10 months, the per member per month for their diabetics went down $46.37. For the pediatric asthmatics, again, some reductions, not as dramatic as the diabetic. Next slide, please. This, after the first year, we always have a celebration where we look at what we've been able to achieve the first year. This is our governor, Ed Rendell, and we had nets up, and every balloon represented 10 people who had their blood sugar under control. That was the red ones, or had their cholesterol under control. That was the green ones. And so when the governor walked in, we just let loose with all of these balloons. It was a lot of fun. Next slide, please. So we started in light blue in the southeast, and we've rolled out to a number of other regions. We always have a local regional steering committee to get buy-in from the local payers and the local PCPs and communities and patients. And we did not start out saying this is a pilot. We started out saying we want to transform healthcare across the Commonwealth, and we're going to learn as we go, and we're going to modify as we go. So we learned from the first-year experience in Southeast that asking practices to get NCQA certification in the first 12 months meant that they spent a heck of a lot of time writing policies that NCQA required and applying for certification instead of really transforming how they were providing health care. So in subsequent rollouts of learning collaboratives, we've pushed that back to 18 months. We really have 4 payment methodologies going. I showed you the one for Southeast with the $20,000 infrastructure payment and then a payment upon NCQA certification. When we rolled out to South Central, which is the brown, and Southwest, which is the purple, we continued, the payers continued the $20,000 infrastructure payment, but they instead gave $1.50 per member per month in the first year for care management to increase resources for care management in the practice. And then in 18 months, they gave an additional $1.50 per member per month if they reached level 1, and an additional $1.50 per month per member per month if they reached level 3. So it's a change in really dedicating resources early on to care management. When we moved up to green in the Northeast area, Geisinger had already a shared savings situation going, which they wanted to continue. So we have an entirely different situation up there. Right off the bat, the practices get $1.50 per member per month for practice support. That would be the equivalent of the $20,000 infrastructure payment that we made in Southeast, South Central, and Southwest. And then they get an $1.50 per member per month in month 4, additional for care management, for resources to dedicate to get care managers in place. And then depending on how many performance criteria they reach, there are 14 performance criteria. Some are mandated, and one of the mandated one is NCQA certification. They can get, if they reach all 14 criteria, 50% of the cost savings. And that's determined on a risk-adjusted basis from what the anticipated costs were versus what the actual costs were. And that goes down on a sliding scale to 41% of cost savings if 9 of the performance criteria are met. If you get 8 or fewer, then there's no shared savings. And this has resulted in payments of hundreds of thousands of dollars to practices through this shared savings model. And then the fourth payment, and it's not really a payment, but the fourth model that we have going are in Northwest, which is the yellow, and in North Central, and another learning collaborative in the Philadelphia area. Practices were given a one-time grant of $12,000 to participate in the learning collaborative and do all the things that the others were, but none of the other payment enhancements. The exception to that is that Independence Blue Cross, which is the largest commercial provider in Southeast Pennsylvania, is changing its payment so that there's one payment for primary care if you're not NCQA certified, and there's a higher payment if you are. So we have people going through this in order to get that higher payment that goes across the board. Next slide, please. So you can see the numbers, they're kind of itsy-bitsy. We've got right now 171 practices involved, representing 780 PCPs. We're close to 1.2 million patients. You can see the practice size is pretty small. We're pretty rural in Pennsylvania. We have about 20, the commas are not in the right place. We've brought in an additional $26 million in payments to PCPs, and that does not include the shared savings, so we think it will be well over $30 million in additional payments. Next slide, please. This just shows you by state NCQA, patient-centered medical home recognition. And I think what's funny here is that if you look at PA, the level 3 is the predominant one, and I don't even know why they have a level 2. There are very few level 2s in any state, we probably because of this incentive and work with the practices are leading the country in certifications. Next slide, please. We had a number of anticipated gains that we hoped we would see. We were looking for improved quality within the first year, and I think we clearly have seen that. We want reduced both ER and hospital admissions in 3 years. We're beginning to see that. Improved access with open scheduling and improved member satisfaction, and anecdotally we're really seeing that. We want to make sure, we want to really support primary care in our Commonwealth and have it be a good profession to go into. And what's been fun for me with this is you see the practices starting out, the first learning collaborative, and their body language is horrible. They all think they're giving tremendous care. And then once they look at their patient registry and they see that their patients are only getting about 50% of care, they really get very competitive about driving their numbers up. And I have not been in state government my whole life, thankfully, but I've got to tell you how many times I've been hugged in these learning collaboratives, and doctors and nurses have said to me, "I like the practice of medicine again. This is the most exciting thing in my professional life." And so I think it really is helping to support primary care in a wonderful way. And, you know, obviously we're learning as we go, and we're trying to share with other states so they don't make the same mistakes that we do. But I think each state is going to be its own brand of primary care. Next slide, please. So I want to show you some of the run charts that we produce using our patient registry. We've got about 26,250 diabetics right now involved, and about 5,600 pediatric asthmatics. Next slide, please. And you can see trying to get some of the out-of-control blood sugars down, and you know, the run charts are going in the right way, but it's still too high. Next slide, please. Looking at percent of patients that have their blood pressure under control. Next slide, please. Or nearly under control. Next slide, please. And cholesterol, which is tough. Next slide. And you can see we're the run chart's going in the right direction. You make some real initial progress, and then it begins to level off, and that's where the hard work begins in working with patients on patient self-management. Next slide, please. So the next thing we've really been working on is behavioral health integration. We've had the physical health payers bring their behavioral health subcontractors in and really try to identify practice that can collaborate both with the behavioral health and physical health that can co-locate in the primary care practices. This is a work in progress for us. But I think we've gone a long way with very few resources. There are 4 of us in state government that are doing this part-time. I think if anyone had asked in a year and a half after starting the first collaborative that we would have 783 PCPs with over 1 million patients involved and could pull down over $30 million in additional payments for primary care, I think I would have said, are you crazy? But it's happening. And we're starting 2 more learning collaboratives in the Southwest, one in the Southwest and one in Lehigh Valley, where you can really make changes quickly. And just start doing it. And it's really fun. And I just can't encourage you more to have fun with this. We're really looking forward to Medicare with their waiver. As Jim discussed, we're just hoping that they're not going to try to disrupt the payment arrangements that we've spent so much time negotiating with the payers. We're adding shared decision-making to our learning collaboratives. We're excited about that. We think it's an important component of the patient-centered medical home. We too wanted to do ACO. We were not able to have Dartmouth pick us. Part of our problem is that we don't have the luxury that Vermont does of having hospitals that don't compete with each other. We think that the ACO model is really critical. We've seen our practices have a decrease in specialist referral, which is great, but the specialists have told the payers, well, okay, so we're not getting referrals as much from the practices in the learning collaboratives, but guess what? We have a standard of living, so we're just going to up the periodicity with which we see the other patients. And so I think until we have integrated ACO model, it's going to be hard for us to really change the growth in healthcare curve. The challenge that we have right now is our administration ends next January, and we need to find a safe home to make sure that this work continues. Right now it's in the Governor's Office of Healthcare Reform, which was created by executive order, and may not continue once there's a successor governor. So I guess we are here in Pennsylvania. If there's anything we can do to help you all, we'd love to do it, and really appreciate the opportunity to share what we're doing.
Well, thank you, Ann, very, very much. I'm going to start with questions again. Just to understand the payment, first I have to tell you how wonderful it would be. I don't think there are any state employees on the line, but having been married to one for 26 years, he doesn't get hugged a lot. That would be, it's worth doing right there. Also, I think the idea of as somebody who used to work at an FQHC, the FQHCs teaching academic medical centers. I just have a wonderful picture. You've just made my day in my head about non-compliant patients. I love that. Just to understand the payment. So you gave a flat amount. I'm assuming it's per PCP for them to join the Learning Collaborative, and then they got it per member per month, $1.50. And then was everybody getting the shared savings, or was that?
Yeah, it varies by regional area, okay, and I can send you a chart that kind of lays that out if you would like.
Yeah. So, but everyone in that area was being paid the same way. So
everyone in the region is paid exactly the same way.
Okay.
But there are 4 different models of payment that we're using because we've kind of. Well, we started on Southeast, where we paid $20,000 for the initial infrastructure to get started, and then that chart I had on there about level 1, 2, or 3 and the size of the practice, you got a lump sum every year based on where you were certified as NCQA. The problem with that, as I said, was 12 months. They really were not transferring practice. They were doing policies and trying to get NCQA certification. And number two, when they got that lump sum payment, the anticipation was that it would go into care management resources for the practice, and that didn't always happen. So then when we went and started the next 2 learning collaboratives, we changed that so we had dedicated resources for care management. And then when we went up to Northeast, they had this shared savings model going, which was a variation of the lump sum payment upon certification. And they had 14 performance criteria with some mandatory, and one of the mandatory was NCQA certification. And so we're trying out the Geisinger, so-called Geisinger model up in the Northeast.
Now the shared savings comes at the end, it comes later rather than an upfront lump sum, but they were willing to invest anyway.
Yes. Well, they're getting $1.50 per member per month for just being in it. They're getting an additional $1.50 per member per month in month 4, which they're to use for care management resources. And then after 18 months, they're eligible for shared savings if they meet the required performance criteria.
Okay. And how did you decide where you were going to start? Did you take applications like Vermont?
Yes, we did. We used all of the primary care associations and the medical society, and we let people know of the opportunity. People applied. For instance, up in the Northeast, they have a lot of older people. So we had some practices that had like 85, 90% Medicare, and that just wouldn't work for them because Medicare fee-for-service wasn't applying yet. So, you know, we would talk to the practices, let them know, you know, the kind of time involvement and effort it was going to take. Some people would drop out, withdraw their application, and we winnow it down. We found that 30 to 50 practices in a learning collaborative is pretty much the max. The practices shamelessly steal from each other. It's so much fun to see. They monthly share data, and they can see exactly how the other practices are doing. So they'll say, "How did you get the foot exams up to 100%?" You know, very easy. We take as soon as the patient goes in the room, we take off their shoes and socks, and those little toes are looking right in the doctor's face. You know, and so it's been fun. And you think how competitive in our state, how competitive the medical systems are, and all that has fallen away. And you know, they're just primary care practices trying to get as good as they can, and the shared learning is exciting, and they're a big part of the presentations in the 7 days. We'll identify someone who's really doing something novel and fun and that's working, and they'll present a session. So I've never been involved in a learning collaborative. I was a little concerned about how that would work, but I must say I've just been absolutely stunned by how great it is, and the and how it works to really engage practices over the long haul on a very difficult transformation.
Great. Jennifer Jaff has a question. What is the role of the patient in care management, and what sort of feedback have you gotten apart from health outcomes?
Sure. We did a baseline with patients and with a control group on patient satisfaction, how they're feeling about access, quality, etc. The role of the patient obviously is to be part of the care team, in fact the center of the care team. The thing that's been, I think, interesting, particularly with the physicians, is that is helping the patient engage in taking control of certain elements of their lives that affect their health. So instead of you going in for your annual physical and the doctor's saying, lose weight, and then you come back the next year, lose weight, and then you come back the next year. You really need to lose weight. Having part of the team work with the patient to identify goals that the patient wants to do, goals that the patient can succeed on. And perhaps it's a diabetic who's overweight, and you say, you know, do you want to lose weight? Yes, I'd really like to. You know the things that that you crave and that really are the things that get you in trouble. You know, would that be a good place to start? Yeah, that would. Well, what are they? Well, I love chocolate. Okay, how much chocolate do you? I have a little bit every day. What do you think a reasonable goal would be? You know, can we try every other day? Yeah, I'll try that. And then giving a call to them or bringing them into group visits where they talk about nutrition and whatever, and everyone in the group visit wants to be losing weight, and it becomes a support system for them. Connecting them with community resources that help them meet their goals. They may come in if they have a chronic condition that needs a lot of attention once a month, but the other 29 or 30 days they're going to be out in the community. So hooking them up with walking groups or other community resources that would help them, help support them in meeting their goals. And it's been a hard thing, particularly for some of the doctors, to learn and understand and to devote resources to, but it's also the thing that really changes people who have had their blood sugar, their blood pressure, their cholesterol out of control for years to really begin to be able to bring those things down.
Well, this is great. I want to thank you very, very much, you and Jim both, and we will have more questions. You will be sorry. See, actually, Ann's email address is now up, so everybody can write that down, and we can ask our questions. So I really want to thank you both very, very much. And remind everybody on the line that we have a webinar tomorrow at noon with Lee Partridge from the National Partnership for Women and Families, who will talk about medical homes in every other state besides Pennsylvania and Vermont. So thank you very much.
Bye-bye.
Bye.